Okay, so you're always worried about status epilepticus. Let's dive into that a bit. So the definition of status epilepticus is 5 or more minutes of a continuous, generalized or bilateral tonic-clonic seizure, or 2 or more discrete seizures with an incomplete recovery of consciousness between the 2 seizures. So the approach is always going to be our ABCs, remembering specifically that if you've got a long period of convulsive seizure activity occurring, there's going to be reduced ability or inability to maintain basically ventilation and oxygenation of the blood, and you need to consider early intubation for patients in this setting. Ideally, put the patient into the recovery position. Obviously, this can change if they're having active convulsive seizures, but the recovery position is ideal. Then again, we want to find out about the history. We need to speak to the relative if we are able to, while someone is getting the rest of the aspects controlled. We need to find out about the time of the onset of seizure. A lot of the management of status epilepticus revolves around the time of onset of seizure, and they all get broken down into different time blocks, basically, according to how long the seizure has been progressing. We need to find out what happened immediately preceding the seizure, were there any specific triggers that we can find, and then also we could do an examination looking for the causes that could be occurring and looking for reversible aspects too. So this is what our recovery position looks like. I'm sure we've all encountered how to do that. So as I said, the status epilepticus management is broken down into different phases. There's early, between 5 and 10 minutes, established between 10 and 30, and refractory, which is between 30 and 60 minutes. For early status epilepticus, the main priorities here are to stabilize and to support the ABCs. We want to identify and treat our underlying cause, and we want to try to abort our seizure. In established status, we want to prepare for intubation and ventilation, as well as referral to a higher level of care. So whether that's a high care within your facility, ICU in your facility, or transfer after stabilizing, that needs to be kind of considered and being prepared. In refractory status epilepticus, here you're dealing with a huge risk to this person's kind of well-being going forward. Here the person should be in a high intensive care situation. You need to have advanced ventilation settings being considered, very close monitoring, and here you'd be wandering into the realm of constant infusions. So early status, the guidelines talk about level 1 interventions being benzodiazepines, and here it gets again broken down into IV, if you have IV access, no IV access, or if you've got no IV access and no access to midazolam. So we're well aware that there can be stockouts of things. Sometimes we can't get access to not just veins, but also medication. So it's quite nice that the guidelines have made provision for this. So in terms of the kind of the top line of each thing, so if you've got IV access, you want to give lorazepam 4 milligrams IV. If you don't have IV access, then you do midazolam 10 milligrams IM, or buccally, so within the mouth, using the IV preparation. And if you've got no IV access and no midazolam, then you could give clonazepam 1 milligram IM. So those are just the top lines. So this is the kind of overall aspect of our early status. So as you can see, as I said, it's a level 1 intervention with your benzodiazepines, and there it breaks it down. So if you do have IV access, I spoke about the lorazepam. So you give it 4 milligrams IV, but not faster than 2 milligrams per minute. Bear in mind that benzodiazepines all carry a risk of respiratory depression. So that's something we need to be considering. If you don't have lorazepam, then you can use your midazolam. If you don't have that, you can use diazepam. So diazepam can go IV. I just want to say a note here. Diazepam IM is erratic absorption. You're not sure what's going to happen. It might all go through as a bolus later on and cause huge problems with the respiratory aspects. So IM diazepam is not a good or safe idea. All right. And then, or you can give clonazepam. If you don't have IV access, then you can do your midazolam, as we spoke about, your IM or your buccal. If you don't have IV access and no midazolam, you can give clonazepam or diazepam, and you can actually give diazepam rectally as a 0.2 to 0.5 milligram per kilogram single dose to a maximum of 20 milligrams. If the seizure is not resolving after your 5 minutes, subsequent to your first dose of benzodiazepine, so remember you want to find out your seizure onset, how long that's been going, as well as when you start to do interventions so that you can have those running concurrently. If it hasn't resolved, you can repeat your dose of benzodiazepines. And then if they are still at high risk for recurrent seizure, you can start your anti-seizure medication. So in established status epilepticus, here you've got, this is lasting between 10 and 30 minutes. Now you're going to be talking about your level 2 interventions, which is your anti-seizure medication. Again, here it gets broken down into 3 different aspects. So if you have IV access and it's not, the seizure trigger is not suspected to be because of a drug or a toxin, then there's a specific management. Here you would give phenytoin. If you don't have IV access and it's established status, then you would give levetiracetam, and that's a 60 milligram per kilogram dose. This would be crushing the tablet and going down a nasogastric tube. If it is due to suspected drug or toxin-induced poisoning, basically, or trigger, then you would go through to your level 3 interventions, which we'll speak about in a moment. So basically here, this is just the screenshot from the guidelines, and it basically speaks a little bit more about the specifics of how to provide these. So just an important note. For your phenytoin, it's 20 milligrams per kilogram, diluted in 200 ml of sodium chloride. Okay, so of normal saline, do not put it into dextrose-containing fluid, and you must administer it no faster than 50 milligrams per minute. And this is usually correlates to between 20 and 30 minutes. And importantly, if your phenytoin goes in too quickly, you can develop cardiac arrhythmias and cause even more problems for your patients having status epilepticus. So if you've got a drug or toxin-induced seizure, here, what you're going to do is you'll go straight through to your level 3 intervention, which we'll speak about, and I already spoke about the levetiracetam as a nasogastric tube administration. Established status epilepticus, here we're speaking about our infusions, basically. So here we need to get onto propofol. This starts with a bolus, 1 to 2 milligrams per kilogram as a bolus, and then subsequent a 1.2 milligram per kilogram per hour infusion. If you don't have that, or you're not able to do kind of rate minders, so this becomes very tricky with these infusions. Then you could use midazolam, and this is 0.1 to 0.2 milligrams per kilogram as a bolus, and then 0.05 to 0.5 milligrams per kilogram per hour. Okay, so there it is, basically there it is spoken. This is just kind of expanding on it. So you want to prevent your recurrent seizures if the epilepsy is diagnosed as suspected. You want to continue your treatment, and you want to continue your infusion for 12 to 24 hours after the last clinical or electrographic seizure. So this is when it becomes a bit more tricky. If you don't have an EEG, but you basically nearly kind of induce the coma in your patient, it's difficult to see if they are or not having seizures. So after the status, we talk about the immediate post-ictal phase. We want to keep the person null per os. We need to consider post-ictal delirium and clarify your cause for your seizure. You may not have found it yet, but you need to focus on really trying to hone in on that, whether it's from a toxin, whether it's from a meningitis, whatever the cause might be, you need to look for it actively, aggressively, and treat it. If a person develops confusion or agitation post-seizure, then we need to consider post-ictal delirium, also called post-ictal psychosis, and we need to do active follow-up. So we need to make sure that we are following them up on the anti-seizure medication as required, and we need to plan follow-up and clarify very carefully for the patient, for their family, and for any healthcare workers that encounter them, what management needs to occur. All right, back to our normal flow.
Sorry, Dr. Comley, would you mind change your PowerPoint presentation to a normal slideshow?